Bismillahirrahmanirrahim. Assalamu alaikum everyone. On behalf of Pakistan Society of Internal Medicine, I welcome you all in this fourth session of online course of hypertension. I'm Dr. Hina Latif, working as assistant professor at King Edward Medical University. We all know that hypertension is the biggest contributor to global burden of disease and mortality, accounting for 1.13 billion population worldwide, with 24% accounting for men and 20.1% accounting for women. The aim of this course is to equip our participants with the skills and tools to diagnose and manage hypertension. We have acclaimed international and national faculty on board. In previous three sessions, we have covered pathophysiology, the burden of hypertension, blood pressure monitoring and measurement, and along with that, the evaluation of hypertension and hypertension-mediated organ damage. Today's session is all about some components of diagnosis and therapeutic goals, along with some non-pharmacological aspects of management of hypertension. So let's start our today's activity without any delay because each minute counts. I formally welcome my worthy chairperson for today's session, Dr. Muazzam Beg Mirza. Our speakers of today's activity, Professor Tariq PSIM and Dr. Feba Sayyed, are esteemed faculty members and our panelists on board. Welcome you all on board. So let me brief you about today's session format. For those who have joined for the first time, we're going to have two presentations. Each presentation is preceded and followed by a pre-test and a post-test to have a comparison at the end so that we may be able to know what you have gained from this course. We also have a question and answer channel port where our attendees and senior colleagues can ask their queries and our senior faculty members will try to resolve them by texting. We're going to take some questions live on the screen as well, which are of utmost importance to make this forum more valuable and to take it as a healthy activity. So let's have a brief formal introduction of our chairpersons for today's activity, none other than Dr. Muazzam Beg Mirza, who is consultant physician and a cardiologist. He is FRCP London, Edinburgh, and Glasgow. He is FCCP USA, a graduate of King Edward Medical University. He had his early post-graduation from USA and UK. He worked as consultant in UK, Riyadh, and Kingdom of Saudi Arabia. Back in Pakistan, he was chief of medicine and cardiology at Ittifaq Hospital, where he started first pain center or first chest pain center as well. He received National President's Award of Pride of Performance. We welcome you, sir, to this galaxy of shining brains. We are pleased to have you here with us. So moving on to our first presentation of today's activity, which is on cut points of diagnosis and therapeutic goals, by our first presenter, a name which needs no recognition, Professor Tariq PSIM, an epitome of knowledge, a great clinician, and a matchless teacher who is always there for his patients and his students. Being the best graduate of QMC and a fellow of Royal College of Physicians, he has served the humanity for so many years as a professor of medicine at King Edward Medical University and at Allama Iqbal Medical College. Currently, he is serving at Akhtar Said Medical and Dental College as Professor of Medicine. He is Senior Vice President Research in Pakistan Society of Internal Medicine as well. Let's welcome Professor Tariq PSIM for his talk on cut points of diagnosis and therapeutic goals. Thank you so much, sir, for being here with us. May I request you, sir, to please display your first slide and have a few words about your topic. Right. We're going to run our pre-test poll and then we will have your discussion.
Thank you. Over to you. Right. So let me have my screen share. Do I have my screen shared?
Yes, sir. It's visible.
Right. So thank you, Hannah, for the kind introduction. And we have been in this course for last 3 weeks, this fourth of session of this course. And we have, as you already said, that we have covered the pathophysiology and how to take or record blood pressure and then how to work up. Today's presentation, my presentation would be a simple one. We have to get onto the cut points at which level we have to label someone to be hypertensive first time. And then, of course, taking into care of that we do not overdiagnose and we do not miss certain patients. We'll be talking about white coat hypertension and we'll be talking about masked hypertension as well. And then we have to set a therapeutic goal that to which level we want to bring that blood pressure down and without any harm to the patients. And finally, we have to set a cut point that where we should be saying it that this patient now needs to be referred to a specialist rather than being managed by primary care physician or family physician. So that's what my roadmap would be. So you can start with the poll as well.
May I request IT team to run the pretest poll? Okay, it is here. Maximum participation from attendees is requested because this course is only for you people. An impressive activity. We have quite a number of participants and mashallah, they all are trying to participate. So we are almost done with our pretest poll. It's the fourth question displaying. Okay, sir, it's done from IT team. Over to you, sir, for your talk. I know you can manage including
right.
time.
So what the pre-poll suggests that the majority of the people are well aware of the targets and goals, and my job is easier one. I'll just be going back to share screen. There is some, right. So what we'll be talking about would be most of it has been, say, based on the published data from International Society of Hypertension. It is the most recent one, the June 2020 recommendation for global hypertension practice guidelines. Few facts about the hypertension. In the beginning, Hina did mention about that almost 1.39 billion hypertensive patients worldwide. Out of that, 1.04 billion are in low and median income countries like ours, and that's where the most of the problem is. Only 349 million in the high income countries. And if you talk of the awareness, 67% of people living in high income group are aware of their hypertension, where the figure is quite, say, alarming that only 38% in our part of the world are aware that they are hypertensive. We have had a session on this, that how to accurately record the blood pressure, and Professor Munir Azhar had a wonderful demonstration of how the blood pressure has to be recorded, and I hope that this slide is being displayed just to highlight that. So how do you make a diagnosis of hypertension? Whenever possible, the hypertension diagnosis should not be made on a single visit. That's the first thing. Usually you have to have 2 to 3 visits, maybe 1 to 4 weeks apart, depending upon the blood pressure level. If the blood pressure is high, you may have a second visit 1 week later, or if it is borderline, you can ask the patient to come after 4 weeks. The diagnosis can be made on a single visit if the blood pressure is up to or more than 180, 110, and there is evidence of hypertension mediated organ damage. So if that is the situation, you need not to go for a repeat visit or recheck or anything. You can make a diagnosis and may plan a strategy accordingly for a drug treatment or whatever intervention you feel necessary. This is, Bilal may not like it, but so goodbye to you, my trusted friend. We have known each other since we were 9 or 10. That's a famous phrase from a song. So these apparatuses, they have served for more than a century, but nowadays, most of the observation made by these are observer dependent. You have to have a good auscultative skill. You may miss the diagnosis in some time, particularly if the blood pressure is being recorded by a physician or someone, which creates a lot of some anxiety into your patients. So we have to move forward, and the world is moving forward. We have to start on recording our blood pressure with the digital blood pressure apparatus, which takes away the observer necessity to be present, which takes away the auscultation to be done, and which is more accurate. Most of the apparatuses available are validated, and they are. And in some cases, we might have to go on to further, say, refinement of diagnosis by checking the ambulatory blood pressure monitoring. So cut points for diagnosis of hypertension depends upon where the blood pressure is being recorded. Is it being recorded in physician office? Is it home blood pressure monitoring? Or it is ambulatory blood pressure monitoring? And that's if the initial diagnosis is made in the office, how this patient needs to be followed up. So if on a first visit, blood pressure recorded is less than 130/85, and there are no additional cardiovascular disease risk factor present, this patient should be rechecked after about 3 years. But if there are risk factors, the patient needs to be re-examined after 1 year. But if your blood pressure reading is found to be on a first visit between 130 to 159 and 85 to 99 diastolic, if possible, I'm saying if possible, confirm with out of office blood pressure reading like ambulatory blood pressure monitoring or maybe home blood pressure monitoring. This may not be possible in our patient in most of the cases in the primary physician or practice, or depending upon, of course, ABP is not readily available. Home blood pressure monitoring, most of the patient find it difficult to say cope with it. So in that case, we may have to have a repeat office visit. But once this blood pressure in the first reading is 160 over, more than 160 over 80, confirm within few days or few weeks. So this is the same shown in an algorithm form, that an office measurement, you use average of second and third reading after 3 readings taken with an interval of maybe few minutes. Blood pressure less than 130, 85, you no risk factors, you examine after 3 years, and if there are risk factors involved, after 1 year. But any blood pressure of more than 130 systolic and 85 diastolic, we need to confirm either by home blood pressure monitoring, self-monitoring, or if available by ambulatory blood monitoring. Now the reading less than 130/85 or on 24-hour ambulatory reading of less than 130/80, this means that you probably need to re-examine this patient within a year. But any reading of home blood pressure monitoring or 24-hour monitoring, home blood pressure monitoring 135/85, or a 24-hour average of ambulatory blood pressure monitoring of 130/80, hypertension diagnosis is confirmed. Why we need to do this home monitoring, why we need to do this ambulatory monitoring? That's because of 2 things. One is the white coat hypertension phenomena, which means that the office BP may be more than the out of office or home blood pressure. 10 to 30% of the patients do have a white coat effect, and the difference may be as high as 20 millimeter of systolic and 10 millimeter of diastolic. Magnitude of this observation or white coat effect may depend on if the multiple blood pressure readings are taken, if it is taken by a senior physician, or it is recorded in very young or very elderly people. The chances of having white coat hypertension are more. The opposite is the masked hypertension, that blood pressure in the office or clinician, the physician office is normal, less than 140/90, which we have set a cutoff value, but elevated in the home, or when you are recording it either through ambulatory blood pressure recording or home blood pressure recording, and it is usually more than 138. Now, this is important. This is the patient which a physician is going to miss out, although he also has a risk of developing complication as equal to as the patient who is hypertension. And this phenomena is seen in almost 10% of the general population. The home blood pressure monitoring would provide us information of evaluating the white coat hypertension. It would help us in monitor response to therapy. It would help us improving adherence to therapy, and it may be the home blood pressure monitoring average reading of 135/85 is considered hypertension. When you talk of ambulatory blood pressure monitoring, which means that you apply a BP apparatus to your patient's body, and then the cuff is programmed to be inflated or recording blood pressure every 1 hour or 2 hours as you set in. And then it takes on an average of a 24-hour, average of daytime, average of nighttime, average of sleeping time. Now, this would be required, one, to probably check out the white coat effect. Now, if the 24-hour average of blood pressure recorded through this methodology is more than 130/80, it is hyper. If the daytime or during the awake period hours, the average reading is more than 135/85, this is hyper. And if during sleep, the average blood pressure recording is more than 120/75, this is again high. And if there is absence of nocturnal drop in blood pressure by 10 to 20% of the daytime reading, this patient also is at an increased risk of cardiovascular events. And now you can understand that why there is a lot of emphasis being put on, say, out of office recordings and out of office reading of blood pressure to make a diagnosis. So in summary, the hypertension diagnosis would be made in office in a visit. If it is 180 over 100 on single visit and there is evidence of hypertension mediated organ damage, which would be talked about by Dr. Somya in the probably next presentation. But any reading of 140 over 90 on first reading, which is confirmed on two subsequent readings, is hypertension. On ambulatory, 24-hour average of more than 130/80, daytime average of 135/85, night times or during sleep average of more than 120/70. And when you are recording home blood pressure monitoring, where you take maybe one reading in the before breakfast and one reading before retiring to sleep, and they take an average of that, and if it is 135/85, it is hypertension. And sometime we did talk about isolated systolic hypertension being labeled as a systolic blood pressure more than 160, but a diastolic of less than 90. Now these are the figures. After we have labeled that the patient has hypertension, we usually grade it or we classify it. So normal blood pressure would be anything less than 130/85. High normal would be in the range of 140/90, less than 140/90, or 139/89, less than that. Grade 1 hypertension up to 140/159 systolic and 90/99 diastolic, and grade 2 would be. And why it is important, that is when we devise a management strategy for these patients, this comes into consideration, that what is their patient's grade of hypertension. Now, once we have labeled that the patient is hypertensive, when should we start the treatment? That is threshold for treatment. That depends upon your age of the patient. That depends upon degree of overall atherosclerotic cardiovascular disease risk. It depends upon hypertension grade. It depends upon hypertension mediated organ damage, and it depends upon access to healthcare, resources, compliance, because many of our patients may not be literate enough or trained enough to have a home blood pressure recording. Many of them may not have an access to ambulatory blood pressure recording. Similarly, compliance to get the blood pressure recorded repeatedly or to visit a physician may not be that good. So all these factors would decide that what do you decide for your patient, either a diagnosis and treatment on a 1 or 2 visit alone, or you want to have a repeat visit to confirm the diagnosis. The first thing after the age and grade of hypertension is that you have to check the overall atherosclerotic cardiovascular disease risk of your patient. And again, there are so many of calculator available, various apps are available. You can use any of these apps for estimating the risk of, say, cardiovascular disease in coming next 5 to 10 years. And these are the type of, say, observations you need to put in into that to calculate the risk. Once you have calculated that risk, it then, as you can say, you can be either your patient may be falling in, say, high normal category and no risk factors, so the overall cardiovascular disease is low, as opposed to someone who have a grade 2 hypertension and already had hypertension mediated organ damage or CKD or diabetes or maybe other cardiovascular disease events like a previous stroke or MI. So he is in a high risk category needing an early or urgent attention. Why do we focus on cardiovascular disease and hypertension? Because it's the leading cause of morbidity and mortality. Almost 37 million deaths per year are related to hypertension-related cardiovascular diseases, and there is an increased risk of undergoing a CV event when with increasing blood pressure. That's why that we are paying so much of attention to estimating the overall cardiovascular disease risk, not the hypertension alone. What are our goals? So we have decided that the patient is hypertensive, and then we have decided that what is the urgency for treatment, and then our primary goal is to prevent cardiovascular events. The risk of cardiovascular disease begins at 115/75 and doubles with each increment of 20 into 10. That's why there is a talk about that should we take 120/80 as normal or 115/75 normal, because already at the level at which we are starting treatment, the patient has 2 times the risk as compared to the population having blood pressure less than. So there is a debate, and similarly, why we set a 20/10 target increment, because this increment of blood pressure doubles the risk of cardiovascular events. So by just lowering this much number, you almost reduce the future cardiovascular events by 50%. And we also have known that the benefits of lowering blood pressure. So if you reduce the blood pressure systolic by around 10 to 50 millimeter, it is 5 years cardiovascular mortality is reduced to 1/3. So our goal is not just reducing the number. Our goal is by reducing the overall cardiovascular disease risk. So once we have established the hypertension, we have established the cardiovascular disease risk, how do we start with? We start with lifestyle advice, and Dr. Fiba is going to talk about shortly on this. And if your patient falls on this, now the International Society of Hypertension have mentioned the essential things which are probably must be done in each and every case of hypertension, optimal, that whenever possible, available, they should be opted for, or they should be the target. So grade 1 hypertension, those with cardiovascular disease risk of more than 10% or a CKD, diabetes, or hypertension-mediated organ damage would require an immediate drug treatment. And the essential is that if suppose there is a limited availability of drug, and that is the issue, then you go on to this with the age group wise, that if the lifestyle intervention for 3 to 6 months and then followed by drug treatment. But optimal would be that in these patients, after observing 3 to 6 months period, if they don't have any risk factor, do start treatment after 3 to 6 months, or if they do have risk factors, you probably go for treatment there and then. But all grade 2 hypertensive, it is essential that immediate drug treatment should be started. This is what ISH is recommending. So putting in a tableted form, this hypertension grade 1, age less than 50, no cardiovascular risk factor or no hypertension-mediated organ damage. The intervention is lifestyle modification for 3 to 6 months, and follow up, start drug treatment if lifestyle, say, measurement or lifestyle measures alone would not be sufficient to control the blood pressure. Grade 1 hypertensive, age 50 to 80, no risk factors, lifestyle modification for 3 to 6 months, but you consider early drug treatment in this group. If you maybe in younger patient, you are waiting for 6 months, here you may be waiting for 3 months only. Grade 1 hypertension, any age, but there are atherosclerotic cardiovascular disease risk factors present, you must start with lifestyle modification and immediate drug treatment. And our aim is to bring it to normal level. We will be talking about shortly what level we want to achieve within 3 months. Grade 2 hypertensive, any age, and there are maybe risk factor present or not, there should be lifestyle modification along with drug treatment. And again, our aim is to bring it to normal, attempt to bring it to normal around within 3 months. The target blood pressure, how much lower we want to go, what we essential is, as we already said, that a reduction of 20/10 from the baseline and ideally to less than 140/90 is our aim to be achieved within 3 months of start of intervention or medication. Optimal is that if your patient is less than 65, you target a blood pressure of less than 130/80 if tolerated, but should keep it above 120/70, not less than that. That's what ISH recommends. But if your patient is 65 year plus, the BP target should be slightly higher, not lower, to avoid the risk of frequent falls and the postural hypertension, all that. So you target it to less than 140/90. If tolerated, you can probably individualize it to be further lower down, but that again would be dependent upon subsequent visits and patient response to therapy. So the BP reduction targets are that to all ages, we have to have a reduction of 20 millimeter of systolic and 10 millimeter of diastolic for all ages, for all groups. Less than 65, again, essentially the same to be achieved, but optimal would be that it should be less than 130/80, but preferably keep it above 120/70. But those more than 65 years of age, the optimal is that keep it less than 140/90. The question is, if the risk starts at 115/75, why don't we bring it further down? Lower, the better. Further lowering of systolic blood pressure less than 130 may be beneficial in select group, not everyone. Too much lowering of systolic blood pressure, particularly in elderly, may carry risk of adverse outcome. So there are some differences between different, say, societies' guidelines over how much lower. The treatment goal as for International Society of Hypertension is systolic blood pressure less than 140 and diastolic of less than 90. Some previous guidelines have recommended treatment values of less than 130/80 million mercury for patients who has diabetes, who have chronic kidney disease, or maybe coronary artery disease. But the evidence to support that this lower target in patients benefits them, it's lacking. So we stick on to the ISH guidelines. Equally important is that when you should refer your patient for a specialist care or say concerned specialist, one, when urgent treatment is needed. So whenever someone has an accelerated phase of hypertension with diastolic blood pressure 120 with papilledema, hemorrhage or exudate fundus examination, he should be referred to specialist. Whenever there are impending complications like TIA or left ventricular failure, he should be referred. Whenever there is an hypertensive emergency, encephalopathy, eclampsia, or aortic dissection, he should be referred. Sometimes there may be an underlying secondary cause for hypertension. This also needs to be referred, and these are the indicators. Aziz Sab elaborated on these in the previous when we started the workup of a patient of hypertension. So anyone with hypokalemia, bruit, elevated creatinine, proteinuria, sudden onset or worsening hypertension or resistant to drugs should be, and younger than 30 should be. And Professor Solit last time talked about BP variability. Now these are the individuals which needs a special care, special attention by the concerned specialist. Sometimes there may be therapeutic problems. There may be multiple drug intolerances. Patient may have multiple drug contraindications. Patient may have persistent non-adherence or non-concordance. Now, all these patients needs to be referred. Now, the take-home messages from my side would be: from diagnosis, record blood pressure accurately. Proper sized cuff, digital BP apparatus are preferred both for office and home blood pressure monitoring. Consider home blood pressure monitoring or ambulatory blood pressure recording when you want to rule out word coat effect or masked hypertension. Diagnosed hypertension when the office reading is more than 140/90 and has been confirmed twice. Home blood pressure reading average is more than 130/85, or ambulatory blood pressure 24-hour average is more than 130/80, or a daytime average of more than 135/85, and nighttime average of more than 120/70. When you start treatment, consider age, consider overall atherosclerotic cardiovascular disease risk, presence of hypertension-mediated organ damage, hypertension grade, and resources to devise a management plan. All hypertension patients should be advised lifestyle modification plans. Initiate drug treatment immediately in patients with grade 2 hypertension or grade 1 with 10-year ASCVD risk of more than 10% or evidence of hypertension-mediated organ damage. Essential goal is to achieve a reduction of 20 by 10 millimeter in all patients. Aim for a BP goal to be achieved within 3 months. For those less than 65, BP goal is less than 130/80. For those more than 65, goal BP is 140/90. In time referral for cases that may require multidisciplinary care. The goal is to get to the goal, reduce BP by at least 20 by 10 millimeter in all patients with hypertension. Measurement and goals should be provided to the patient verbally and in writing at each office visit. So that's what I have to say about the right. Okay.
Thank you so much, sir, for such a valuable talk.
Right.
We had a number of questions from our participants and Professor Azizur Rahman, mashallah, continuously answering. We have hands from few participants. We will unmute them one by one to have their question. In the meanwhile, may I ask Professor Shehbaz Qureshi to have some comment on the given presentation?
Thank you very much. I think Professor Tariq Wasim gave an excellent talk. He covered everything and the targets that we need to achieve, the cut points while measuring blood pressure in the office, ambulatory blood pressure monitoring, home blood pressure monitoring, and the incidents that we had. We talked about goodbye, my trusted friend. And I want to make a little clarification here. The mercury sphygmomanometer actually is now being discouraged because of the toxic effects of mercury, and it is not being used in most of the countries abroad. And we should also actually do away with it. But the aneroid BP apparatus actually is quite useful and should be used in the office. Normally, when we say a validated automatic blood pressure recorder, what it should really mean is that we have validated it against a standard BP apparatus like a mercury sphygmomanometer or an aneroid blood pressure apparatus. And every time when we are taking the blood pressure readings there, we take 2 to 3 readings with the automatic blood pressure recorder or a digital recorder, and then take an average of the last 2 readings. But what I have observed is that after 2 weeks or so, when the batteries wear out, the recording or the reading is not valid. And this should be made sure that the batteries are new and we are able to actually record correctly. That is very important. Then the other point which he also brought out was that a blood pressure of 115 and 75, and from there on, there is an increase in the risk of the hypertension-mediated organ damage. Perhaps what one should be able to understand is that as we are in the domain of 130, 35, or 85, even if the blood pressure is low here or is normal, we should understand that as the age advances, this blood pressure is going to rise. And perhaps that is what is being meant with that. And when we are talking about the risk profiling, I was giving a lecture in one of to the general practitioners and to even to the cardiologists and the physicians. And I said that I will close my eyes. So all those who use these risk calculators, please raise their hand. and they were less than 10%. So I think not many people are using the risk calculators, and it's not actually needed also. What is needed is that we define the optimum blood pressure goal, which we should take as 140/90 and less than that. 140/90 is hypertensive, and we need to treat it and to bring it down. How much lower that we bring it down? I have been a cricket player all my life, and I know that if you pitch the ball in the good length, that is the area where it will be of the best use to you as far as your bowling is concerned. And therefore, you have to don't get obsessed by numbers. Look at the range. Remember, it is a range of blood pressure. Never bring it down to 120/70. We say that. And then we talk about 115/75. So I think it is important to understand that you bring down the blood pressure. The goal should be to bring it down to less than 140/90, not to be obsessed by numbers, and never bring it down to less than 120/70. The other thing which perhaps needs a little clarification is the International Society of Guidelines when it says optimal treatment and essential treatment. What it means is that in those areas where there is no resource limitation, you can use the drugs as prescribed by the guidelines. But when you have a resource limited area, like a low income country or somebody who comes to you with a background where he cannot or she cannot afford the medication, then you use whatever is available and the essential medicines which are needed here. Now, the other thing is, we must remember another point. The essential component of ISH says, bring down the blood pressure to less than 140. The optimal says, bring it down to less than 140/90, and the essential says, bring it down to 20 systolic and 10 millimeters diastolic. Now tell me, if somebody comes to me with a blood pressure of 180/100 and cannot afford, and I bring it down to 20/10, this patient is still hypertensive. Even though the guidelines, when they are being written again and again, many, many times, and they do a lot of work on it. But I think here there is a little something to be thought about, that it is not the blood pressure of 20/10. If the blood pressure is 180/100, the person at 160/100 is still hypertensive, and you need to treat them. So basically, the goal should be 140/90, less than that. Never less than 120/70. Now, whatever readings you can have them in the home blood pressure reading or ambulatory blood pressure recorders, whatever you have. Always bring the blood pressure to less than 140/90 in a range. Be a little bit more aggressive with diabetics and CKD. And remember, one thing is very, very important, and that is hypertension does not come alone. It comes in a cluster. It comes in a metabolic syndrome. And I'm sure that when we are going to talk about lifestyle management, we are also going to talk about something which is known as sustainability. How much can we sustain that? So these were the few comments that or some clarifications which I wanted to make.
Thank you so much, sir, for such a detailed comment. Let's request IT team for a post-test analysis, for a post-presentation poll first. And then we're going to have our comparison, and Professor Tariq will comment on it. We do have some questions from our attendees who are raising hand. We will take all of you one by one. Just be patient. So we are almost done with our poll test.
Right. Do I need to
For the results, may I request to unmute Dr. Vikas
comparison?
from the attendees so that he might be able to ask his question. Dr. Vikas Ahmadjan, are you able to talk?
You need to do lots of a comparative analysis first. Comparative analysis.
No. Comparative analysis will take some time to be prepared.
I think it's already, we have.
Because they are the cornerstone of this. I'll request all others to please mute their mic. Okay, can we have Dr. Altaf Chima?
Yes.
Yes, sir. So please go ahead.
My question is that in those patients who are above 65 and the recommendation is their blood BP should be brought down by below 140 by 90. If a patient can tolerate low blood pressures, can we lower it to 120 by 70 in patients who are above 65?
Yes. Also, we did mention
And
that we have to bring it down to the maximum tolerable. So even the elderly group, Shabazz Saab also commented on that to get maximum benefit out of this. And this all depends upon how frail your patient is, what are his chances of having.
If they can tolerate, we can bring it.
130/80. For
If
that,
they can tolerate, we can bring it down.
Up to 130/80, not lower than that, because
Not lower than that.
Right.
So
Thank you so
another comment is that Professor Shabazz Saab has said that affordability. We have seen that even triple combinations by good pharmaceutical company is available only for 10 to 12 rupees. And we have been using that. We are having good results. So affordability should not be a problem these days.
This is actually
Yes,
when we are
but
talking
that's-
about the essential component and the optimal. Obviously, if a person can afford the treatment and can continue and sustain the treatment, it is not something to be given for 1 month or 2 months or 3 months. It has to be a lifelong treatment. If the treatment is sustainable, in that case, you will go for the optimal management. In those cases where the treatment is not affordable or the patient cannot afford to continue it for a long time, then obviously it is whatever drugs are available to bring the blood pressure down as much as possible. The ISH says 20 by 10, and I have some differences there because, as I said earlier, if the blood pressure is 180 by 100, when the patient comes to me and I treat the patient and bring it down to 160 by 80, I should not be happy about it because the patient is still hypertensive and therefore the treatment is needed.
No, that's right. That's right. But I was talking about the and
Okay, thank you. We will take few questions, but the pre and post test poll comparison is here, and I would request Professor Tariq to comment on it. May we have the pre and the post test comparison displayed, please? Here it is.
As I said in the beginning, that we had quite a knowledgeable audience. They already knew most of the things, and so there is, in fact, after the post test, some of them thought that 140/90 is not the right. Okay, so we go on to the second question? Okay, there is some improvement that lifestyle modification of 3 to 6 months followed by drug treatment is the right strategy. Next. And there is, of course, we made public aware that the prevalence of white coat effect is quite high. So just don't jump onto the diagnosed hypertension on a single reading or a single visit. Do reconfirm it. Next. Again, there is some improvement that the minimum requirement which you want to achieve after your intervention is a reduction of 20 millimeters systolic and 10 millimeter diastolic. And if you achieve that, you have some success. Of course, you need to bring it down to less than 140/90 or 130/80 in select groups. But this is what minimum is required. So again, sometimes you have patients who come up with their blood pressure 200 or 130 था, 180, 90 तक आ गया, लेकिन अभी भी normal नहीं है. So you have to emphasize on that continuation of treatment because it still is benefiting them. So that would be my comments on this.
Okay, sir. Thank you so much, sir. Maybe we'll take one more question from our participants. I can see Professor Khalid over there with a raised hand. Can we unmute him? Professor Khalid, can you hear us?
We are running short of time. We need to move to the next speaker now.
Let's move to our next presentation.
Assalamu alaikum. Excellent talk by Professor Tariq Wasim and excellent question answer session by Professor Azizur Rahman. My only observation regarding digital BP apparatus is that as Professor Shahbaz already said, because of battery issues, readings are too much high or low. So that is my observation. Otherwise, excellent talk. Thank you very much.
Thank you so much, sir. Without wasting any single minute, we need to move to our next presentation. Thank you so much, Professor Tariq Wasim and our panelists for commenting on it. We all know health is not just a goal, it's a way of living. And these lifestyle modifications and non-pharmacological interventions can help reduce the daily dose of antihypertensive medications and can delay the progression from pre-hypertension to hypertension. To have a talk on non-pharmacological therapy in hypertension, we have Dr. Fiba Sayed with us, a beauty with brain, I must say. She is serving as assistant professor at Shaheed Zulfikar Ali Bhutto Medical University, PIMS. She is MRCP UK, she is FCPS Medicine and Fellow of Royal College of Physicians, Edinburgh, and specialty certified in the field of diabetes and endocrinology. We welcome you, ma'am, over here. May I request you to please display your cover page of today's presentation and introduce your topic. After that, we're gonna have pre-test poll and later on we have your pulse of knowledge. Over to you, ma'am.
Thank you very much, Dr. Hina, for a very gracious introduction. And I would like to congratulate Dr. Tariq Wasim on a wonderful presentation. So without further ado, let me just share my screen. I hope that my screen is visible.
Yes, ma'am. Yes, ma'am, it's visible and on slide.
Okay. Thank you very much. So we will be going on to discuss the non-pharmacological management of hypertension. And I think for our part of the world, it's important, just cannot be undermined. So before I formally begin my presentation and go into the facts and figures of what the scenario in our country is, let me just ask the IT support to display the pre-presentation questions, please.
I request my IT team to please display pre-test poll. Okay. So we are almost done. Over to you, ma'am, Fiba, please.
Okay, thank you. When we discussed the MCQs, I think one of them had one of the options missing. And so we'll discuss this one when we come to the post presentation evaluation. So Bismillah ar-Rahman ar-Rahim. Let's just start with the presentation now. So starting with the reality check, let me just touch base and remind all of us of our humble beginnings. We all believe that 10 rupees per day pill might be something that everybody can afford. But let me just remind you that our children still search piles of trash every day just to find scraps of things that they can sell in return for meals. The average annual income, mind you, annual income is 71,000 rupees per year. It is 6,000 rupees per month. And with 6,000 rupees per month, they generally have 7 to 8 mouths to feed. 25% of our population is below the poverty line. And yet, a very striking contrast is that according to the Diabetes National Survey, up to 26% of our population may have diabetes or prediabetes. 18% of the population is hypertensive, which we all know is just the tip of the iceberg. 25% of the population is obese or overweight. And we have the second highest consumption per capita of trans fat. 1 in 5 persons smoke. So here, the only thing that I would like to stress upon is that medication might not be something that we can all afford. And we must look back to our rural areas, to the people who we really are, not just a subgroup who can afford all the amenities of life. And it is, no matter how much I stress, the most important message to remember is that we must stress on lifestyle modification, not only for the treatment, but also for the prevention of all these non-communicable diseases, as Dr. Shahbaz mentioned. It just comes in a cluster. So we'll just go on from here. The agenda of today's presentation is that we're going to meet our patient. We will be formulating a management plan, followed by a glimpse of the non-pharmacological management. Then we'll do some deep diving into each intervention. And finally, you'll have a chance to assess yourself once more. So let's meet our patient. A 35-year-old male presents to you with a history of occasional headaches and palpitations. He is otherwise well and has no significant past medical or surgical history. There is a family history of hypertension. He smokes half a pack per day since the last 5 years and is on no regular medications. On examination, he's got a blood pressure 140/90, which has been checked several times, and his BMI is 28. Rest of the examination is unremarkable. So points to ponder. Should we start with non-pharmacological therapy? Should we be instituting drug therapy simultaneously? Are there any other obvious contributory factors in our patient? What additional interventions may be beneficial to our patient? And how long must the non-pharmacological measures continue? So this has been taken from the International Society of Hypertension Guidelines, and it's been discussed in the previous presentation as well. But just to revise once more, that once we have established the diagnosis of hypertension, lifestyle advice goes without saying for anybody who's been diagnosed with hypertension or is at a risk for hypertension. If your patient presents with grade 2 hypertension, then obviously the first thing you do immediately start drug therapy. However, if our patient has grade 1 hypertension, which means 140 to 159 systolic or 90 to 99 diastolic, and our patient has hypertension-mediated organ dysfunction or is at risk for cardiovascular disease, chronic kidney disease, or diabetes, then we might start immediately drug treatment. However, if there are no such risk factors, then we can give the patient a trial of 3 to 6 months of lifestyle advice before we go on to drug therapy. So in our patient, the obvious contributors are obviously his family history. He's a smoker, and obviously there are issues with his weight. Now, when we talk about hypertension in an individual or in a community, it depends on a number of factors. It depends upon your genetic makeup. It depends upon environmental factors, for instance, your weight and your diet, your smoking maybe, your physiological factors, which might include your age, and the clinical factors, for instance, chronic kidney disease. Out of these, The modifiable ones, that is the environmental factors, must be taken into account so as to reduce the blood pressure. So let's take a look at the non-pharmacological measures at a glimpse. We will be talking about salt reduction, healthy diet and healthy drinks, weight reduction, smoking cessation, regular physical activity, and stress and mindfulness. So let's go on and dive deeply into each intervention one by one. So why have I put up this interesting picture? This is a lady and her baby. Both of them belong to the tribe of Yanomami Indians who live in Brazil. Now, this is a tribe of which consists of 200 to 300 villages, and they've had almost no interaction with the modern world. There is no urbanization, and their diet is as simple as it was many years ago. For 90% of our journey of human evolution, humans mostly had a plant-based diet. And since the last 10%, we've switched on to more of an omnivorous and rather a carnivorous diet for that matter. So these people, the only source of salt that they have is that through fruits and vegetables. And their intake is around 200 milliequivalents per day. Now we'll be coming to the RDA, but generally the RDA is 2,300 milliequivalents. The WHO says around 2,000, the AHA suggests 1,500, but generally their intake is much lesser as compared to what is recommended. And as a result of this, their individuals mostly have a blood pressure of around 95/61, and they will not have an age-related rise in blood pressure. We know that up to 90% of the individuals will have an age-related rise in blood pressure, and through their diet, they've been able to blunt that. So for a 60-year-old person who's born in the Yanomami tribe, he'll have a blood pressure which is equivalent to an infant born in the modern world. And if we compare that to northern Japan, where the intake of salt is around 10,500 milligrams per day, there's a striking contrast. And the human body has this ability to process salt and just take in what is required through varying the secretion in the salt and the loss through the kidneys. Going on from here, so most of the sodium in the diet, basically 90% comes from the salt. And salt that is required is just 180 milliequivalents, milligrams per day to maintain the balance in the body. So as we know, the Yanomamis just take 200. And obviously, even if you take up to 10,500, you will maintain your normal sodium levels. Most of the sodium in the diet, of the salt, actually comes from processed foods from grocery stores. So this means everything that is packaged, from your sausages to your frozen food, frozen meat slices, pickles, canned food. And this constitutes a lot of the diet of the modern times or the urban population. 15% comes from restaurant meals. 13% is added while eating or cooking, and 4% is found naturally in food. So just imagine what would happen if we would just be taking this 17% and excluding that from restaurant meals and processed foods. People from Pakistan as well as from the US generally take double the amount that is recommended. So there's a strong relationship between the intake of salt and blood pressure, and we have a high capacity to survive at extremes of intake, as I've already discussed. Now, just mentioning salt sensitive and salt resistant individuals. Not every individual will have a response to the intake of salt. The majority will, but there are individuals who are salt sensitive. The definition is the amount of blood pressure that rises when you take the amount of salt. So if the blood pressure rises, you're called salt sensitive. And if the blood pressure does not rise with an increase in the intake of salt, you're called a salt resistant individual. And this is arbitrary. There is no unified definition, but there are individuals who will not their blood pressures will not respond to an increase or a decrease in salt intake. So salt, generally, if you reduce the salt, the blood pressure will fall for most individuals. It will also prevent you from going on to developing hypertension if you're at risk. The greater the age, the more the chances of you being responsive to a low salt diet. Black individuals generally respond more, or African Americans will respond more as compared to the non-African Americans. And individuals with diabetes and chronic kidney disease will also respond more to reduction in the salt intake. Another very important fact is that sometimes we've all seen patients who, when they're started on medication, will pop in a pill and just forget about their intake of salt, and will have a ball of a time with as much of salt intake as they require. But once you actually reduce the amount of salt in your diet, your blood pressure becomes more dependent on angiotensin II. And hence, it becomes more responsive to the use of ACE inhibitors and ARBs. Salt intake has an independent effect on proteinuria. So it will also reduce your progression to renal disease. There is a great mortality benefit. I'll be quoting figures from the US because we don't have any statistics for our own country. But generally, if you reduce the amount of intake by half or come down to the RDA, in the US, they estimate that they will save up to 100,000 lives per year. So how much blood pressure can actually come down if you take the recommended daily allowance? For African Americans, it's 9.5 systolic to 5.2 diastolic. For non-African Americans, 6.8 systolic to 3 millimeters diastolic. And resistant hypertension, the reduction is strikingly high. That is 22.7 systolic and 9.1 diastolic. So just a slide upon the mechanism of salt-resistant and salt-sensitive individuals. Salt-sensitive individuals in response to salt intake have an upregulation of the mineralocorticoid receptors and hence blood pressure elevation. However, salt-resistant individuals will have a downregulation and hence there is no increased sodium absorption and they will have a normal blood pressure even if they take an excessive amount of salts. So coming on to the role of diet. We all know the most famous is the DASH trial, that is the dietary approach to stop hypertension. This typically is a diet that is rich in fruit, vegetables, legumes, non-fat dairy, and is low in snacks, meat, sweets, and saturated fat. Now, when we talk about a diet that's rich in fruit, we're referring to 4 to 5 servings every day of fruit, and each serving constitutes one medium-sized fruit. We're talking about 4 to 5 servings of vegetables, which is around half a cup of cooked vegetable. And for non-fat dairy, it's 2 to 3 servings per day, which is equivalent to each serving would be equivalent to 1 cup of either milk or yogurt, or if you talk about low-fat cheese, it would be just around 2 teaspoons. And we'll be coming to the legume recommendation in just a bit in the next slide. So if you follow a DASH diet and combine this with a low sodium diet as well, you are likely to have an 11.5 millimeters of mercury fall in blood pressure, which is equivalent to pharmacological therapy. Talking about healthy drinks, there is some data on the moderate consumption of coffee, green and black tea. I must remind you that, however, individuals who are not used to the intake of caffeine or coffee, once they start it, immediately there might be a rise in blood pressure. But those individuals who are generally used to the intake of coffee, it might have a beneficial effect. There is also a positive linear association between alcohol consumption and the prevalence of hypertension and cardiovascular risk. Now, talking about potassium intake, and I'll be coming to a slide later on, but just to tell you that where we are overshooting in the intake of sodium, we're underachieving what we require. So when I talk about potassium intake, it does not mean supplementing through medication. It means meeting the RDA. So only 1% of the females and 10% of the males are actually taking their recommended daily allowance of potassium. And we'll be dwelling into this in one of the later slides. But however, if you take the normal recommended potassium, which most of us don't, it will reduce your blood pressure by 5 to 3 millimeters of mercury. Again, this means maintaining the RDA, not overshooting it. Fish oil. Now, through the polls, I realized that all of us and most of our patients are very fond of fish oil. So fish oil, when it causes a reduction of blood pressure, number one, the reduction is just very, very modest, up from 2 to 1.6 millimeters of mercury. And the doses at which fish oil actually reduces blood pressure are of at least 3.7 grams per day, which are humongous doses. And at these doses, number one, we don't know much about their safety over long term. Number two, at these doses, it has a tendency to cause bleeding. It has a tendency to cause impairment of renal function and a tendency to actually cause a deleterious effect on the lipid profile. So fish, there has been a trial on the use of fish along with weight reduction, and very significant reduction in blood pressure from 133 to 119 systolic and 87 to 78 diastolic when both of these were combined. Again, high fiber diet, magnesium and folate will cause a modest reduction in blood pressure of 1.3 to 1.2 millimeters of mercury. So just a bit more about the DASH diet. We've talked about the daily recommendations of fruits, vegetables, and dairy. But what about whole grain? So we require 6 to 8 servings per day of whole grain, which would be equivalent to 1 7-inch chapati, or maybe half a cup of brown rice. That's 1 serving. And then one slice of brown or bran bread. And when we talk about the servings of nuts and legumes, it's 4 to 5 servings per week. And each serving of legumes would be just around half cup. And of nuts, it's around a handful per serving. So going on from here, and just because this is something that's not generally discussed and something interesting, we just dwell a bit upon potassium. So low potassium intake, that is when you do not meet the RDA, it increases blood pressure, increases the risk of stroke and chronic kidney disease. High potassium intake, which again, I do not mean excessive potassium intake, but maintaining the RDA of 120 milliequivalents per day or up to 3,700 milligrams per day reduces blood pressure. And how does it do so? It reduces blood pressure through, when you have a low potassium intake, there is activation of the WNK pathway, which causes activation of the sodium chloride co-transporter, which is going to reabsorb more of sodium and hence cause a rise in blood pressure. A meta-analysis of 11 studies showed an increase in potassium intake by 1.64 to meet the RDA actually reduced the risk of stroke by 21%. And again, supplementation to maintain the RDA, because most of us are not having enough, reduced blood pressure by 5 to 3 millimeters significantly. So it is recommended that patients with hypertension who have normal renal functions, not at risk for hyperkalemia, should maintain a high potassium intake from fruits and vegetables, that is, through the diet alone. Just a bit about weight reduction. So, weight reduction causes a significant fall in blood pressure, but you require at least a 4 kilogram of weight loss to have a 6 millimeters of mercury systolic fall in blood pressure. Weight accounts for 26% of the hypertension in males and 28% in females, and it also increases the risk of cardiovascular and all-cause mortality. The mechanism by which weight causes a rise in blood pressure is unclear, but there are a number of hypotheses, including hyperinsulinemia, sleep apnea, the activation of the leptin-melanocortin pathway, which causes increase in the sympathetic discharge, an upregulation of the mineralocorticoid receptors, and increase in the salt sensitivity. And a sustained loss of 6.8 kilograms is associated with the relative risk of developing blood pressure by 22%. Now let's go on to another very important part of the lifestyle modification, that is smoking cessation. So we all know that's a major risk factor for cardiovascular disease, COPD, and cancer. In Pakistan, 1 out of 5 people smoke. In Pakistan, we lose 160,000 people because of smoking every year. Smoking has a noxious effect through an increase in the sympathetic activity, and it also increases the myocardial oxygen requirement and induces arterial stiffness. The incidence of hypertension is increased amongst those who smoke more than 15 cigarettes a day. But even 1 cigarette will cause a transient rise in blood pressure, and it may be missed if you take a blood pressure later than 30 minutes. When you stop smoking, the arterial stiffness that has been induced by smoking will persist for at least 10 years, even after you've quit smoking. And cessation of smoking can rapidly lower the risk of cardiovascular heart disease by 30 to 40%. Coming to the effect of exercise. Now, there are a lot of different types of exercises, including dynamic aerobic exercises. Dynamic generally means that you're moving your muscles and the joints for purposeful activity. There is dynamic resistance exercises, and there are isometric exercises. Most of the data comes from dynamic aerobic exercises, which means things like running, jogging, brisk walking, swimming, and in the most RCTs, there's a mean reduction of 10.8 millimeters of mercury systolic and 4.7 millimeters of mercury diastolic. This is just a very teeny weeny bit less as compared to that which is achieved through the impact of diet and salt reduction combined. So what are the recommendations? The goal is that in general, it's reasonable to have 150 minutes of dynamic moderate intensity exercise per week. That is 30 minutes, 5 or more times per week, and at least 75 minutes of vigorous intensity physical activity per week. When we talk about vigorous intensity physical activity, it means high bursts of physical activity followed by some degree of rest period, again followed by high intensity physical activity. So in the US, 8 out of 10 people do not meet this recommendation. And I don't know about your experience, but as far as I'm concerned, I think for our population, it's even less. We're not used to exercising at all. We're just used to more of sitting. And if we walk around, we're active, we generally consider that exercise, which it's not. And lastly, it has been shown that chronic stress does have an impact on hypertension. However, we need more data on this. But there are RCTs on the use of techniques like mindfulness and meditation for the reduction of blood pressure. And these are techniques which do aid in the reduction of blood pressure. So with these, I hope that when you go back to your practices, all of you are going to make an attempt to help all your patients, not only in treating their hypertension through their lifestyle modification, but also preventing the onset of hypertension and all the non-communicable diseases which we know that come in the form of a cluster. I hope you choose to make a difference. Thank you very much. And we can now go on to the post-presentation MCQs.
Thank you so much, sir. May we have our post-test poll? Okay, we are done with our post test. And while waiting for the comparison, first of all, let me welcome our President PSIM, Professor Javed Arkam, who is here with us. I can see Professor Sajid Ubaidullah as well, and Dr. Soumya, who is there from the early start of the session. Welcome, ma'am, and welcome, sir, to the session. May I request Dr. Moazzam Beg Mirza to have few comments about the lifestyle modification or non-pharmacological management of hypertension. Over to you, sir, please.
This is a important subject, and lifestyle modification is desired for all the hypertensives, but more so in grade 1 hypertension. This is the area where this comes into play. The lifestyle has to be changed, lifestyle has to be modified, the salt intake has to be reduced, optimum weight has to be gained, weight between 18.5 to 25 BMI, and we should engage ourselves to the aerobic exercises like brisk walking and other games, and smoking cessation, and alcohol consumption should be reduced, and it is not only the medication, it is the lifestyle modification which is important along with the medication, even if we have to start the medication.
Professor Bilal, if you want to add something to it, please.
Assalamu alaikum. Indeed, a great presentation for the Viva as always, but I'd like to add a few, 2-3 things over here of importance. When we talk of smoking cessation, this is a subject very sensitive to me, and I go after it with big vengeance. Let us be very clear. When we smoke, when we talk of pack years, this is basically a method that the industry of the smokers have developed in order to downgrade what is happening. When you say half a pack, actually, you may be smoking about 10 cigarettes per day. Now, that is a big number. And as Fiba has also pointed out, that you have a cigarette casually once, and then that takes your blood pressure up. So smoking cessation is important, and the cigarette calculation should be based on how many cigarettes you smoke. Packs, for those who do not know, come in 3 different sizes. There's a pack of 10, there's a standard commonly used pack of 20, and then there are super packs, which are like 40. So if someone is having a super pack, then these people would say, okay, I'm just having half a pack, that's 20 cigarettes. So you have to count the cigarettes. Another thing about smoking is that there are 2 types. The old cigarettes, which were filterless, and now the new filter ones. So the filter cigarettes have other sets of problems which have come up as far as we are as cardiologists or as physicians. But for physicians, of course, for oncology purpose, the filters have actually added a lot more also, while they may have decreased something. Then you have cigars, which is another set of things. Then you have the hubble bubble, the hookah basically, and the shisha. These are all tobacco consumptions of various ways, and they all cause problems. Then you have the non-smoke tobacco, the chewable tobacco, the niswar. Now, these all sets have problems. So for us, it is not just smoking cessation, it is tobacco cessation in totality. Then the best way actually to discover and to talk about the person's what is the consumption going on, you should count the cigarettes per month. Someone who is smoking like 1 or 2 cigarettes actually do not consider themselves as smokers. They say, I take a cigarette only going before to the washroom. So there is a different way, but this person is having at least 30 or 50 cigarettes per day. Fiba very nicely pointed out those children in the very first slide who are economically deprived. Many a times I've had these patients who turn around and say that I can't afford treatment. But these patients can afford smoking. So the reality is that a cigarette, which 1 pack of cigarette, the standard 20 packs, low economy one, is about 60 to 80 rupees per day. So they can smoke 50 rupees of cigarettes per day, which is then translates to 1,500 rupees per month, and then to 18,000 rupees a year. And all those figures are in 10 years, risk then becomes a massive 2 lakh rupees. So these things are there. We as physicians must stop saying half a pack or 1 pack. We have to start counting the number of cigarettes. Then if a person actually is not having cigarettes and he thinks he is having a cigar a day, and this does not carry the same risk, you are highly mistaken, because when they have that cigar, they get that kick which the tobacco creates. And this is very much there. After all, it's all sublingual and mouth absorption that is happening. So in all of these facts, wherever there is tobacco, it's going to make a very big difference. As far as exercise issues are concerned, this is for one thing that which is of great importance, and that is the availability of socially permissible areas where people can go and do exercise. Physicians, luckily, are always in a position where they can recommend it to the nationals at a higher level. And FIBA is in Islamabad, where they have these societies, rules and regulations being developed. That's so much area current new societies must have, where people can come in of all ages and have safe and good exercise. This is of extreme big importance, because many times in cities like Lahore and also in cities like Rawalpindi, which have now become very congested, it's not safe and possible actually to go for your regular exercise walks. So the society at large actually has to make an effort that these people can go out for their exercise. As far as the diet, luckily the Punjab government food drug authorities have now come up with they're trying to package out the things that where the contents of the food must be displayed from where the things are going on. FIBA has pointed out many times about USA, and they have got these things going on, but we must sort of encourage these things to go up in our society. With potassium supplementation, there is one big problem. It doesn't have the taste of a salt. And when you try to replace it, actually many times people try to sprinkle a lot of it, and that becomes a problem. So there is a taste bud issue, but then it's always developing a taste into your correct place. There are people who, like me, for example, मैं बर्फी छोड़ता नहीं और चाय में चीनी डालता नहीं. So it is something like you have to develop your taste buds accordingly and then move in that direction. And this is the way it must be done. And I hope there are other people also, so I will not take up too much of more time. And all the best, FIBA. MashaAllah, well done. A good talk, difficult topic, difficult to get your points across, but this is something which needs to be done, and well done, a good handling. Thank you.
Thank you very much.
Our post-test poll, at pre and post-test poll comparison is ready. I would request Dr. FIBA to please analyze it for us. IT team, please display it.
Okay, so for this question, the answer is correct on both pre and post-test polls, and we have a higher number of people who have agreed later on. So the answers are correct. Lifestyle modification was the answer. Next question, please. So for this one, I think there was an error. So here, for the first, one of the options should have been dietary changes. So I would like to again stress, because we learn at any time of the presentation, maybe you missed the point, but when you dietary changes, that is the DASH diet along with low sodium intake, will cause the highest reduction in blood pressure of around 11.5 millimeters systolic. This is followed very closely by exercise, which causes around 10.5 millimeters systolic. So regular exercise would have been closely contested, but the correct answer is dietary changes, which was only picked up by 15%, unfortunately, of the people who are attending. Next question, please. So which of the following statements about salt consumption is correct? So once again, I think maybe the MCQs were a bit difficult, but again, we learn, and we learn more by perhaps making mistakes. So the AHA recommends 2300. So this is, yes, so this is generally correct. but I would like to discuss the rest. Reducing salt intake independently reduces proteinuria. Yes. Salt reduction does not reduce blood pressure in all individuals. We talked about salt sensitive and salt resistant individuals. So it reduces blood pressure in salt sensitive individuals. Salt intake, reducing salt intake makes potassium supplementation more effective. That's incorrect. And younger individuals do not have a greater effect on blood pressure with salt restriction. It has a greater impact on older individuals, and it can help you blunt the age-related rise in blood pressure. Next, please.
May I request Dr. Fiba for some more questions from our attendees? Question number 1 is, ma'am, how to measure salt in the diet? Okay, we are left with the last question.
Okay, so the last question is that 55-year-old female presents to the OP. So it's about fish oils. So for this, the correct answer was that, so let's just take it one by one. Fish oil reduces blood pressure by 10 to 5. It does not. There is a very small reduction of around 2 millimeters of mercury systolic and 1 diastolic. Long-term safety of fish oils is well documented. It is not. Again, this is a wrong answer. The doses required to reduce blood pressure have a deleterious impact on lipid profile. We got most of people to give this answer, and this is the correct answer, because as I mentioned, we require very high doses of more than 3.7 grams per day. But in these doses, there is an impact on the lipid profile, the renal impairment, and a bleeding tendency. Low-dose fish oil does not cause these effects, and it is not recommended. So the answer is the third one, which most of the participants answered correctly. So I'll just take the question that you asked, that is, how do we calculate? So generally because we must remember that we calculate sodium for studies and we calculate sodium for recommending to our patients. So when we talk about our patients, generally 1 teaspoon per day, that is it. 1 teaspoon would mean it covers all your diet throughout the day, and any added salt would not be required. When we talk about the amount of sodium we take in and we want exact precision, for most studies, we're going to calculate the urinary excretion of sodium to do so. And again, that has a lot of limitations. It depends mostly upon the output. And again, that's not 100% reliable, but that is what most studies use. But for practical purposes, just telling our patients, should be aiming for less than a teaspoon a day. If anybody would like to add on to that, please. We have very senior people here who would like to add on to this. I think Dr. Shahbaz would like to add on.
Dr. Akram, if he can add something to it.
Thank you so much, Hina, for a very good moderation and a matching excellent presentation I expected from FIBA, I think, and we are very grateful to my elder brother, Muazzam Beg Mirza Sahab, who hardly ever agrees, but I think I have a prerogative that he never refuses me. So thank you, Muazzam Bhai, for your support, and your presence made all the difference.
My honor.
Sir, it is always a pleasure. I am deeply obliged. You resisted, but not like a resistant hypertension. At the end, I prevailed. So thank you. I just want to add to FIBA's excellent talk. Obviously, not everything is possible to put in one talk, but about calcium. Calcium has a very good role as antihypertensive, shown by 2 Indian studies and 1 of our own study. So calcium should be promoted in the diet, and calcium channel blockers, they do not block the calcium, they are only blocking the influx of the calcium through the slow channel. So that's that also. And on the meditation side, she already discussed about the stress handling and things like that. But we did a study long time ago where we used namaz and zikr and the ambulatory blood pressure, one of the first studies coming out of this part of the world. And we presented in Puerto Rico, very impressive data. And I was grateful to Professor Nawaz Anjum for training our people for namaz and zikr and catecholamine unloading effect. So that is one thing, that anything which takes you away from environment and to reduce your blood pressure and heart rate. About the cigarette smoking, I just want to share with the colleagues, especially my team over here at PSIM, that I am negotiating a very important study with nobody else but Philip Morrison. Philip Morrison are the largest tobacco company in the world. They have, their budget is about thrice as much as of Pakistan. And they have realized it that tobacco smoking is going to go down. So they are innovating ways how to stay in the market and not go bankrupt. So they have come with a very good initiative, which we called harm reduction. That if best thing is if people can give up the smoking altogether, that is the best thing that can happen to them. But second best thing is to make this tobacco smoking less harmful. So I am already doing a pilot with them where it is called heat not burn tobacco through an IQOS device. IQOS is the I quit ordinary smoke device. And very soon we will be through SOMIA, we will be inviting people who want to participate in this study. They will be, of course, providing IQOS devices where tobacco smoking continues, but we heat and not burn tobacco. We know that nicotine is the addicting substance, but the harmful substance comes from burning. More than 4,500 petrochemicals comes through one smoke. And this is from the paper that you burn or the tobacco that you burn. So that can be reduction. And then it can act as also as a bridge to give up later on. As far as the exercises, Bilal mentioned that we need the proper environment. With due apology from my younger brother, I don't agree. I think if somebody is committed to exercise, floor exercises are good enough and everybody can do it. But I think as a physician, we need to be role models. I Alhamdulillah, try to be regular with my exercises, and I really encourage my patients to join me in exercise. That's the best thing you can do to your patients. If you are exercising in the gym or whatever, in a group or whatever, encourage them to do so. PSIM very soon will launch a campaign in exercising, and we will have videos that we will be able to give to public. And I am preparing those videos with my trainers at Shapes. I got special discount for my patients from Shapes, and the time I go is early morning, and many of my patients join me there. They feel more confident, and after looking at me that I am exercising, they also, the compliance increases. About the omega-3 and the fatty acid at the end, I think I take omega acid for increasing in HDL and not decreasing the lipid profile as a whole. That's one, and also it has a very minimal effect on the blood pressure reduction, as Fiba said. But I think the main advantage is in people who have low HDL, there is a low cutoff that they do increase the high density lipoprotein more than increasing the low density lipoprotein. So thank you so much to everybody for a wonderful treat. Okay, over to you, Hina.
Thank you so much, sir. Dr. Fiba, can you please comment on vaping and e-cigarettes? Someone asked from our participants. Also, we talked about e-cigarettes as well. Dr. Bilal had some talk about it.
Vaping has its own set of issues. Now there are new diseases which are called vaping-induced lung problems, which are coming up. As Professor Javed Akram has very kindly pointed out that, these things are being there, and Philip Morrison is doing this work, and we are looking into this angle. But the reality is that, as Javed Saab has also said, that the best thing, of course, to do is that we must stop smoking. But if you can't stop smoking, then you have to go for the lesser devil. But when you're going for the lesser devil, you must always point out that this devil is not the best devil to be on. You need to get rid of it. And that is something that is there. Just taking on Professor Javed Akram for the fun of it. Sir, not everyone can afford going to Shapes. Not everyone can afford going to these various places. Not all families can go out because they have the vehicles. I am talking of the masses at large that you need. Our country does not exercise, period. And that is the problem where my issue is. As far
I
as
think they can all do floor exercises, as I said.
Sir, वो जो
Make videos.
मोटी
They all
जो
have
बुढ़ी
the
औरतें
phone.
आती है ना, उनका मसला है. And when I ask them to do it, so it's always, yes, these are all the difference of opinion, but mastered services for the masses at large. That's what I'm trying to point out. हम लोग आजकल साफ पानी की बातें करते हैं. Of course, luckily we are not one of those, but there are people, and the very first slide that Fida actually showed was about going to the masses at large. So this vaping, though is coming up, is there, but it is not the real place, because the nicotine, the addiction is still there. And and actually what happens with this, because it looks very cool, you're doing it, and it has that aroma also. So many of them actually, if a cigarette lasts you about 5 minutes, they keep on whipping for about half an hour. So it's going to be a very interesting find out that if you're not using burnt tobacco, but warm tobacco, and burnt tobacco for 5 minutes and warm tobacco for 30 minutes or 40 minutes, where are we actually following? So this is going to be a big long-term study, but as Professor Javed Akram has kindly said, it's Philip Morrison doing it. They want to look into it and find more ways. Pakistan is the second cheapest country in the world. After Afghanistan, we're the cheapest to buy cigarettes. And one of our main things when you're traveling abroad is they check in your baggage if you're carrying any cigarettes with you and above the normal requirements. But anyway, thank you.
For your valuable comment. I would like to request our chairperson of today's activity, Dr. Mozam Beg Mirza, to please summarize the session by adding his valuable pulse of knowledge and to give some take-home message to our attendees, our participants, and our panelists. Over to you, sir, please.
First of all, I must thank the organizing committee of the Pakistan Society of Internal Medicine to invite me to participate in this international symposium or course. I must also thank the learner speakers, Professor Karagwasi and Professor Fiba Syed for their excellent talk. Their talk was very detailed, very exhaustive, and to the point, and very clear. I must appreciate their lectures, and my job was made easier by the comments made by Professor Shahbaz Qureshi, Professor Bilal Mohyuddin, and my brother Javed, Professor Javed Akram. Well, there is nothing much for me to talk because it has already been discussed in detail. Hypertension over the last decade or two is steadily increasing, and it is because of the lifestyle changes and because of the mental stresses, life stresses. And look at the food we eat, the junk food, the cola culture, the sedentary habits, lack of exercises, and obesity. And again, as Professor Qureshi said, hypertension doesn't come alone. It always comes with association. And the associations are diabetes, dyslipidemia, hyperuricemia, and obesity. And it can be a part of the metabolic syndrome. And hypertension is also described as a silent killer. I had a look at one survey year 2016. 45% of the adult population in USA had either blood pressure of 140/90 or they were being treated for the hypertension. And this was USA. And mind you, this figure does not include the chunk of the population which do not know they have the hypertension. In other words, hypertension is undetected. And those who are detected, those who had the hypertension, they were not properly managed. They were not properly controlled to the goal level. And hypertension affects all ages. Of course, it increases with the age, sex, and races. In blacks, the hypertension is more prevalent and the course is more serious. And in general population, hypertension at the age of 18, the incidence at the age of 18, incidence is about 14%. At the age of 40, the incidence is about 40%. At the age of 65 and above, the incidence is about 65%. Hypertensive, majority of the hypertensives are essential or primary, where there's inheritance or genetics or lifestyle lifestyle changes play a role. In younger lot, below the age of 30 or above the age of 50, secondary hypertension comes into play. Secondary hypertension, major cause are the kidney, renovascular causes, and coarctation of aorta, renal artery stenosis. These are the things which we look into. And we have talked about isolated systolic hypertension. We have talked about postural hypertension. We have talked about the white coat hypertension or masked hypertension. Ambulatory BP recording is helpful. Pregnancy and hypertension is another very important topic we have not discussed. And chronic heart disease, chronic ischemic disease, chronic small vessel disease lead on to chronic heart failure. Of course, we must also remember these days obstructive sleep apnea. It causes morning systolic hypertension. So good history taking is important. We have talked about the hypertension goals, blood pressure. European talk about blood pressure of 140/90, whereas American, they have lowered the figure to 130/80. However, in both cases, the target goal is 130/80. In cases of diabetes, in chronic kidney disease, chronic artery disease, pregnancy, or where there is a end organ damage, the more strict control is desired, and to the level of 120/75. Diastolic goal is between 70 to 80. How low we can go, we have talked about. The short answer is 120/70. And when to initiate the treatment, there is a general agreement that the blood pressure of 160/100, we require the treatment. However, when there is a high cardiovascular risk, then the figure can be lowered to 140/90.
Thank you so much, sir, for your valuable comments and for being there with us. With this,
my take-home message is,
yes, sir, please.
Early detection of blood pressure. Number 2, effective and strict control of the BP to the target level.
Sure, sir. Definitely. Thank you so much, sir. With this, our today's activity comes to an end. I hope you all had a great time beaming with knowledge and experience. And I hope you all learn at least something beneficial for you and for your patients as well. Talking about our next Sunday's activity, we're gonna have 2 talks as well on different antihypertensive agents, RAS and non-RAS blockers by Professor Hafizullah and Professor Amir Shokat. I wish you all the best and may you all be able to get the best out of it, and that's what our aim is. I extend my deepest thanks to our worthy chairperson, Dr. Mozambique Mirza, our honorable speakers, Dr. Tariq Wasim and Dr. Fiba Sayyed, our panelists, and to our course director, Professor Azizur Rahman, whose days and night efforts are making it a huge success. Thank you so much, sir, for giving us a chance to clear all myths, queries regarding hypertension via this course. With this, we say goodbye till we meet again next Sunday, 12 o'clock, inshallah, on 20th June. Goodbye from my side. Allah Hafiz.
Thank you, Tariq Wasim and Professor Fida. Thank you for what a wonderful talk and fantastic, and see you next week. All the best. Khuda Hafiz.
Thank you everyone for participating.
Thank you, sir.
Hello, everyone, and bye-bye, everyone. Thank you very much, everyone, for joining. I was a little occupied today, so could not participate actively. Vibha and Dr. Tariq, as usual, were brilliant, and Hina, you were excellent. I'm so glad that we have now good moderators to take over, and I can just relax. Thank you so much. Dr. Kashif Saab, thank you, and IT team, thank you very much.
Welcome, and thank you very much, sir. Aziz Saab, Tariq Saab, Dr. Hina, Dr. Fiba. Thanks a lot. Allah Hafiz.
Allah Hafiz.